Good morning, good afternoon, and good evening, fellow experts and all of you who are attending this meeting. My name is Ning Wang. I'm from Hangzhou, China. It's a great honor to be here today. I would like to give you a brief overview of diagnosis of COVID-19 based on the clinical observations and scientific studies of COVID-19 around the world, and on the basis of the protocol for the management of COVID-19 issued by the National Health Council. With the whole diet, it will serve as a reference for clinicians. Okay, let me start over. Since late 2019, COVID-19 has been spreading rapidly in populations and creating local outbreaks and global pandemics. COVID-19 has become a major concern for hundreds of countries across the world. Infiltrative lesions in the lungs of patients with new coronavirus pneumonia are characteristic of viral infection and have been identified by laboratory tests as a novel coronavirus, which has never been previously detected in humans or animals. Novel coronavirus is transmitted by respiratory droplets and close contact. In addition, novel coronavirus was also detected in high concentrations of aerosols and in feces and urine contaminated by patients. In our country, the epidemiological and clinical characteristics of the disease were analyzed from the very beginning of the epidemic, and a rapid response plan was adopted. Through our tireless efforts, the epidemic has been brought under control to some extent in our country, but the global rate of new infections continues to fluctuate. With the onset of winter and the high incidence of respiratory disease, there is a very long way to go in the prevention and treatment of COVID-19. In the following time, I will focus on the key points of clinical diagnosis of COVID-19, including clinical features, laboratory tests, imaging manifestation, diagnostic criteria, differential diagnosis. Firstly, let's look at the pathological manifestation. According to the results of limited autopsy and puncture pathological specimens, the pathological manifestation of the disease have been increased. The lung, spleen, hair, lymph nodes, and the bone marrow, heart and blood vessels, liver and gallbladder, kidney, and other organs were described in detail from perspective of naked eye and microscope. It is emphasized that the disease is mainly caused by lung and immune system injury, and the other organs mostly belong to secondary injuries. Next, let's take a look at the clinical features. Based on the current epidemiological theories, the incubation period is 1 to 14 days, mostly 3 to 7 days. Based on current epidemiological theories, in the incubation period is 1 to 14. A few patients have symptoms such as nasal congestion, runny nose, sore throat, myalgia, and diarrhea. Severe patients tend to develop symptoms of respiratory distress or hypoxemia a week after onset. Severe cases can progress rapidly to acute respiratory distress syndrome, septic shock, uncorrectable metabolic acidosis, and coagulopathy and multi-organ failure. It is important to note that heavy critically ill patients may have moderate to low fever or even no significant fever during the course of the illness. Some children and newborns have atypical symptoms such as vomiting, diarrhea, and other gastrointestinal symptoms, or just weakness and shortness of breath. In mild cases, the symptoms may include a low fever and mild malaise with no signs of pneumonia. Most patients have a good prognosis, but few are critically ill. The prognosis is worse in the elderly and in those with chronic underlying disease. The clinical course of pregnant women with novel coronavirus pneumonia is similar to that of patients of the same age. In children, the symptoms are relatively mild. Let me explain the laboratory tests. Firstly, in general examination, some patients may have increased liver enzymes, lactate dehydrogenase, muscle enzymes, and myoglobin, and some critically ill patients may have increased troponin. Most patients have increased C-reactive protein and sedimentation, and normal calcium. In severe cases, the dimer is elevated, and peripheral blood lymphocytes and progressively reduce. Inflammatory factors are often elevated in severe and critically ill patients. In pathologic tests, novel coronavirus nucleic acids can be detected in nasopharyngeal swabs, sputum, and other lower respiratory secretions, blood stool, and other specimens by RT-PCR. Lower respiratory specimens are more accurately detected. We should send specimens for testing as soon as possible after collection. In second examination, IgM antibodies specific for novel coronavirus are usually positive 3 to 5 days after the onset of the disease, and the IgG antibody titers increase fourfold or more during the recovery phase compared to the acute phase. Prognogenesis is the gold standard for the diagnosis of viral infections, and the quantitative viral nucleic acid testing can be used to monitor changes in viral load dynamically and thus reflect the efficacy of antiviral therapy. However, this is cumbersome and time-consuming. The results of the assay can be affected by a number of factors, including specimen quality, site of infection, and expression of the virus. Therefore, a single nucleic acid test cannot meet the requirements for rapid screening of suspected cases during an outbreak. Serum-specific antibodies are another key piece of evidence for the diagnosis of viral infection, and antibody-assisted nucleic acid testing can be used to aid diagnosis and rapid screening. Now, let's look at the imaging manifestation in more detail. Due to the lack of specificity in chest radiographic manifestations, no abnormal findings were found in the early stage of the disease. When positive findings were found, most of them were severe lesions with lower sensitivity and specificity and high rate of misdiagnosis and misdiagnosis. Therefore, the current guidelines remind that this method is only applicable to primary hospitals and patients with severe pneumonia. The consensus of imaging experts at home and at abroad on COVID-19 imaging diagnosis is that CT is the main means of screening and diagnosis at present. Chest CT shows early multiple small patchy images and interstitial changes, which are evident in the extrapulmonary bands. This progresses to multiple ground glass and infiltrative shadows in both lungs, and in severe cases, solid lung changes, which may appear as white lung. According to the lesion range, high-resolution CT findings can be divided into early stage, advanced stage, severe stage, and absorption stage. In early stage, the lesions are limited, including single and double lung, multiple ground glass, nodular shadow, patch shadow, and mass shadow. The inner lung texture can be seen, showing grid-like changes, accompanied by thickening and proliferation of blood vessels, with or without thickening of intertubular sputum. This manifestation may be related to the early invasion of the lung parallel around the terminal bronchioles and the respiratory bronchioles, and then evolving the entire lung lobes and the fields alveolar injury. Lesions are mostly located under the pleura and the lateral field of lung in advanced stage. With the progress of the disease, the number of lesions gradually increases. The scope of lesions gradually expands and the lesion fusion occurs. At this time, CT shows ground glass-like infiltration shadow, irregular fan-shaped or wedge-shaped unclear boundary and anti-butterfly wing. Multiple lung lobes are involved. Some lesions are consolidated. Ground glass shadow coexists with consolidation shadow or striped shadow. Sometimes crazy paving sign appears, or fibrotic lesions are combined, and bronchial inflation sign is visible. It is more common in the outer and outer zones of the bilateral lung fields, which may be accompanied by a small amount of pleural effusion in severe stage. CT showed diffuse lesions of both lungs, which could show white lung and crazy paving sign, mainly consolidation with ground glass infiltration shadow. A 50% increase in the size of the lesion at 48 hours is a poor prognosis. In the prognosis stage, this stage is mostly about 1 week after onset of the patient. The lesion scope is reduced. The density of consolidated lesions is reduced, absorbed, and dissipated. These are absorbed or organized by the body, and fiber strips and shadows can be complicated absorbed left behind. Generally, small pieces of ground glass shadows can be completely absorbed, and large pieces of shadows evolve into fibrosis. In Co's study, for example, he reported the imaging features of pneumonia caused by viruses such as influenza virus, adenovirus, cytomegalovirus, severe acute respiratory syndrome virus, coronavirus, and Middle East respiratory syndrome coronavirus. The common features include multifocal distribution, ground glass shadow, nuclear shadow, solid shadow, bronchial wall thickening, and pleural exudate. There is a lot of overlap between COVID-19 and other viral pneumonia CT findings, and the imaging physician needs to combine the patient's exposure history, travel history, first symptoms, and laboratory indicators to make the diagnosis. Although CT is not currently the gold standard for the diagnosis of COVID-19, it still plays an important role in the early screening and differential diagnosis of COVID-19, the detection of suspected cases, and the timely assessment of changes in disease and treatment outcomes. Next, let's take a look at the diagnostic criteria. Firstly, the diagnosis of COVID-19 can be made on the basis of history, epidemiological data, symptoms, and signs, combined with the laboratory tests for viral nucleic acids and imaging analysis. If CT nucleic acid kits and clinical symptoms are combined, the diagnosis can be made with 97% accuracy. In confirmed cases, we should consider the suspected cases with one of the following pathogenic serological evidence. Firstly, they should have positive nucleic acid for novel coronavirus by real-time fluorescent RT-PCR. Secondly, they should have high homogeneity with known no coronavirus by viral gene screening. Thirdly, they should be positive serum novel coronavirus specific IgM and IgG antibodies, serum novel coronavirus specific IgG antibodies from negative to positive are fourfold or more elevated in the recovery phase compared to the acute phase. While there are difficulties in diagnosis and differential diagnosis, greater emphasis should be placed on the clinical presentations. Patients with a history of protein exposure that cannot be ruled out should be considered as COVID-19 patients or suspected cases if they have associated symptoms, imaging manifestations of lung infection and low white blood cells, even if the nucleic acid test is negative. Those who do not meet the criteria for suspicion and cannot be ruled out may be designated as suspected cases based on expert opinion and recommended for prompt isolation. Let's look at the clinician typing in more detail. Some patients with only positive swabs and pharyngeal swabs and no chest imaging abnormalities may be called COVID-19 infected. If there are lung imaging of abnormalities, they may be called COVID-19 patients. Stratification according to the degree of critically can be divided into common, heavy, and critical types. Common refers mainly to patients who present with fever, respiratory symptoms, and imaging pneumonia, but do not meet the heavy and critical presentations. Heavy refers to patients with one of the following conditions. Here are the conditions. Thirdly, critical refers to patients with one of the following conditions: respiratory failure requiring mechanical ventilation, shock, and other organ failure requiring ICU treatment. Now, let's look at the differential diagnosis. The mild manifestations of novel coronavirus infection need to be differentiated from upper respiratory tract infections caused by other viruses. Secondly, novel coronavirus pneumonia should be differentiated from other known viral pneumonia such as influenza virus, adenovirus, respiratory syncytial virus, and mycoplasma pneumonia infection. In particular, suspected cases should be tested for common respiratory pharyngitis by methods including rapid antigen testing and multiplex PCR nucleic acid testing where possible. Thirdly, it should also be differentiated from non-infectious diseases such as vasculitis, dermatomyositis, and Chinese pneumonia. Okay, that's the overview of the clinical diagnosis points of COVID-19. Thank you so much.